Good afternoon, everyone. Nice to see everybody here. So, like Amanda said, I'm going to go ahead and talk to everyone about wires or waves, DBS versus focused ultrasound. Can you all hear me a little bit better now? Just to start off, I'd like to acknowledge the Francis and William Smallwood Foundation, as well as the Dorothy Mangurian Lewy Body Dementia Foundation for supporting my fellowship through my time here at University of Florida. So today I'll just give a brief outline of what we're going to talk about. So we're going to talk about when do we start to consider these advanced therapies, who is really the best candidate for these therapies, and we'll touch base on kind of the history of how we came to these therapies, briefly mentioning our conventional lesioning therapies, then DBS, focused ultrasound, and then we'll get into the who should choose what, and go from there. So, advanced Parkinson's disease is difficult to define. Many people have tried to put scales together, put resources together to really kind of quantify who is advanced in their diagnosis of Parkinson's disease. But ultimately what this comes down to is your clinical functioning through your day-to-day. How are you handling your symptoms and able to move through your day-to-day life? And so with that in consideration, we start to think about who of these patients who are having a harder time managing their symptoms and having a harder time through their day-to-day, who should be given these options. So typically for these advanced therapies, we want to see someone who's having a good, clear response to levodopa therapy. I'll give the little caveat there is that sometimes people who do not respond from a tremor standpoint to levodopa therapy often do respond very well to these advanced surgical therapies. So we have a little asterisk next to that, but for things like stiffness and slowness, that typically responds very well to levodopa. You're going to have a good response to these advanced therapies. We want to make sure that we're in the kind of opportunistic window where we have these troublesome complications, either from the medications that are limiting the amount of medicine that you're able to take, things like dyskinesias, things like nausea, or just intolerance to the medication, or you're having to take it so frequently and able to maintain that on status of your medication, but not so disabled that we're in the phase of Parkinson's that's a bit refractory to these treatments. So we try to assess that nice therapeutic window where someone is at the point where they're disabled enough, but not so permanently disabled from Parkinson's disease that they can have a true benefit from these surgical therapies. The other things that are important to know are having the best expectations for what these therapies can really provide for you. And so these are excellent strategies to help manage a lot of symptoms from Parkinson's disease, but unfortunately, they're not a cure for Parkinson's disease. And so I think it's important to always make sure that we're understanding we can expect significant benefit and improvement in quality of life with these therapies, but it isn't going to take away the Parkinson's disease. And so making sure we have that expectation kind of well managed and understood before going into the surgery is a huge factor in making sure that we're setting you up for the most success in these procedures. The exclusionary criteria really for who can have these therapies is we want to make sure that your diagnosis is clearly a diagnosis of Parkinson's disease. We have not found that deep brain stimulation or focused ultrasound is helpful in secondary causes of Parkinsonism or atypical Parkinson's disease, so things like MSA or PSP. They don't tend to respond as well or have great success with these advanced surgical therapies, so we don't perform for those conditions. There are some factors and features of Parkinson's disease that someone might be experiencing that give us a little bit of pause when we're considering these therapies, and those are namely pretty advanced cognitive impairment or active psychiatric issues, they're not absolute contraindications to having these procedures done, but they are things that we take into consideration, and we really have to weigh more heavily the risks and benefits of undergoing a surgical procedure when these are the more active features of your Parkinson's disease. And so I told you that I put a little asterisk next to the tremor, so we're going to continue to think about this. Why, if my tremor doesn't respond to levodopa, why would it then respond to stimulation? And so I'm going to have you guys hold on to this thought, and we're going to talk about that in a future slide here. So in going through the history of how we get to DBS and focused ultrasound, we start back in the beginning of lesional therapies, or what we refer to colloquially as the conventional otomies. So these include things like thalamotomies, pallidotomies, and subthalamotomies. All that really refers to is the particular type of the brain area that we are performing a lesion therapy into. And so we can see kind of the different targets here and what the typical surgical setup looks like for patients who undergo this otomy therapy. And so what this is really helpful for is tremor, pretty exclusively. And so these therapies are typically performed only on one side of the body because they do have higher risks of side effects when performed bilaterally. The different targets that we focus on in these conventional therapy, or in the conventional otomies, are more focused on tremor control. We'll look at the thalamus, which will not really impact so much the stiffness or the slowness of movements on the side of the body compared to the pallidum or in the subthalamus as well. There are also some more persistent risks of things like persistent dyskinesias that can develop when you're performing a lesional therapy in the subthalamus. And so that's something for us to keep in the back of our minds. As we moved on and as time has progressed, we've developed kind of more advanced surgical techniques on how to better address the symptoms that come up with Parkinson's disease. And so I'll lead us into our deep brain stimulation right now. And this is just a timeline of how we got to DBS where we are today. And so I'll highlight a couple of key dates. So starting back in 1939 is when we really first started to see big surgical treatments relating to tremor. In 1953, we actually saw the first kind of pallidotomies being performed to help alleviate tremor specifically. And then in 1968, carbidopa-levodopa, as Dr. Curry has mentioned, came onto the scene, and we really kind of started to see surgical approaches to tremor, to Parkinson's disease, starting to take the back seat. And that went on until about 1987, when the first deep brain stimulation surgery was performed in the setting of a patient who had essential tremor. And then we move into 2002 when we finally have FDA approval for deep brain stimulation for Parkinson's disease. So when we're talking about stimulation in the brain, we need to know about the kind of pathways and the circuits that we are stimulating. And so whereas the medications can play roles in these various kind of aspects of the circuitry, what the stimulation is looking at is how can we modulate the way that the neurons or the cells in the brain talk to each other to give you a smooth movement and to reduce the tremor that you're experiencing. And so this kind of complicated picture and pathway here involves structures called the basal ganglia, the thalamus, and the cortex. So that's basically your big loop of how you move smoothly through the world in a very kind of crude sense of the way. So when we do something like deep brain stimulation, which is the most frequently performed surgery for Parkinson's disease therapy, what we are doing is we are implanting hardware into the brain that provides an electrical stimulation to try to modulate and provide some stabilization to the aberrant firing networks in Parkinson's disease in that same kind of circuitry pathway that I showed you before. What we look for is that regularization of firing to try to cause smoothness of movement, coordinated movement, and reduction in tremor. So remember our friend who asked if my tremor doesn't respond, and it all comes back to that pathway and those structures that I showed you. The medications play specific roles in some aspects of that, but they don't modulate the whole pathway. And so that's why when we say someone whose tremor doesn't respond to levodopa, we expect it to respond to stimulation or to modulation, is because we are modifying that pathway at a different point from where the medication is reaching. And so that's why when you read, symptoms that respond to levodopa will respond to deep brain stimulation or to a focused ultrasound, but my tremor doesn't, this is why. And so several different groups have been kind of looking into how and what specific aspects of these pathways is this deep brain stimulation causing that modification and affecting tremor in comparison to levodopa. So there's a lot of ongoing work looking into that pathway now. So to give a little bit more of a visual of what does deep brain stimulation look like. So we have our patient here who has an IPG, which is the pulse generator, or you can think of it almost like a pacemaker or a battery, in their chest that's planted under the skin in the chest. There's a wire that comes up the neck behind the ear, and it connects to the two electrodes, if you have both bilateral stimulators placed, that lead into the brain. There's a couple different targets that we can see and use for deep brain stimulation. In Parkinson's disease, the most common targets are the subthalamic nucleus and the globus pallidus interna. Those are both that structure in that basal ganglia area of the brain that I had mentioned earlier. In some cases, we will see in Parkinson's disease that you can perform deep brain stimulation in the thalamus, but typically that's something that we see a little bit more common with essential tremor type tremors. And so just to highlight again, these are those specific areas that we highlight and target with our deep brain stimulation. So when we look at deep brain stimulation as compared to medical therapy, as defined here, BMT stands for best medical therapy. When we look at kind of rates of how people have done and how their symptoms have been managed with time, ultimately, we see non-inferiority between deep brain stimulation and best medical therapy. And in this particular review and study, they actually found that people tended to feel that their motor symptoms improved more so compared to best medical therapy. So when we're considering deep brain stimulation surgery, we want to make sure, again, that we have an appropriate candidate for it. That means understanding what we can reasonably expect to improve with the deep brain stimulator, and that we have a supportive environment that someone is going to really be able to flourish in and thrive after the surgery. This is a brain surgery, and it takes a little bit of time to recover from it. There is ongoing programming because the deep brain stimulation is not a one-time procedure and then things are kind of optimized out the gate. It takes time to really optimize the settings and to control the stimulation that's going to give you the best outcome with your deep brain stimulation therapy. And so making sure that we're aware of kind of the back work after the fact to really optimize our success with this procedure here. The way that we have at UF set up our deep brain stimulation program is we have you kind of meet with everyone and anyone with our team, with our therapists, our social worker, our speech therapists, our neurosurgery team, our psychiatrists, our neuropsychologists, and we're really looking for, do we have the best chance of helping you with this surgery, or are we putting you at undue risk? And so those would be the things where someone has more severe cognitive problems or some active psychiatric illnesses that might pose some complications to therapy down the lines. And do we have symptoms that we expect to get better from deep brain stimulation? And so those symptoms that we really think are going to improve are going to be things like rigidity, bradykinesia, dyskinesia, tremor. There are targets that we can focus on that can aim to reduce the medication burden that people take. And there are also sometimes targets that can help with some of the more axial signs. Those are your things like tripping, falling, being a little bit more midline, having problems, less so with tremor, things like that. But we caution with DBS that it does not often help with cognition, it does not often help with falling, and it does not help with balance. And so those are important factors to really keep in mind when you're kind of deciding, what am I going to use my deep brain stimulator for? If that tends to be the more bothersome aspects of your Parkinson's disease, this is not necessarily the best option for you, and it's something that we have to kind of discuss with the rest of the team to make sure that we're not putting you at more undue risk as a result. So some of the side effects of this procedure in the acute setting when you have the surgery performed, there's risk of hemorrhage, there's risk of stroke, small risk of seizure, urinary retention. These symptoms are relatively low risk when we go into the surgery. They're uncommon, but they are things that can happen, so it's worth kind of noting them. The other potential side effects of the deep brain stimulator are any infections to the hardware because, as I mentioned, we have multiple pieces of hardware that are implanted into the body and that remain in the body, so there's risk of infection there. There can be erosion of the skin from the area, and so we can always keep a close eye, kind of checking on those things, meeting both with the surgical team and the neurology team after the procedure is completed to make sure that we're minimizing any of those risks. And then in the long term, when we've looked at kind of patients who have had deep brain stimulators and followed them out, some people have noted that they feel that their balance had gotten worse after the procedure. Some people have noted that they had some fatigue or felt some depression. A lot of the time that comes from kind of expectations of this was going to make a much more dramatic benefit in my symptoms than what ended up happening. And so we always advise patients of that, and that is one of the reasons that we stress the multidisciplinary pre-surgical evaluation so strongly, to really make sure that we're being as transparent with people as possible as what we can reasonably expect to improve with deep brain stimulation. So right now there are 3 different companies that are offering stimulation equipment and devices. They each kind of have their own unique flavors of things. So their newer kind of outcomes are the sensing and streaming of brain signals that's been done by Medtronic. They've also started releasing a new program called Adaptive, in which the leads and the pulse generator are able to respond to the signals that are firing in your brain and adjust stimulation based on those parameters. With Boston Scientific, they have developed a new technology that they can use AI to merge with your MRI brain and suggest stimulation patterns based on where the lead ends up in your brain. And then with Abbott, less of a newer feature now, but they have the ability to have remote programming where you don't have to come in person, in clinic, for your sessions. And as long as you're able to connect on Wi-Fi, you could be in the comfort of your home, and the clinician could be in their office and be able to adjust your stimulation settings that way. So we'll move on from deep brain stimulation and into focused ultrasound. And so again, we'll start with the history of focused ultrasound. Really, evidence working with ultrasound therapy came out of how it was being used to remove and treat tumors in patients with cancer. And that was happening around 1990s. Starting in the early 2000s, we started to see how could this be used as a therapeutic delivery mechanism, because it can disrupt the blood-brain barrier, which I'll highlight a little bit later, and help with medication delivery directly to the brain. Then in about the 2010s, we started moving into, okay, how do we use this as lesional therapy to help control things like tremor? And then back in 2013, we can see that started being used in essential tremor, and now we've gotten to the point where we are FDA approved now for focused ultrasound unilaterally for Parkinson's disease. So the biological effects of focused ultrasound, in the top row of pictures here, what it shows is kind of thermoablation, which is basically how we perform the lesioning of a specific area of the brain without having to actually cut into the brain. So there's no going through your skull, no going through the other brain tissue. You're able to target specifically where you want the lesion to appear, and you're able to lesion that way. The middle photo on the top just shows some blood-brain barrier disruption. What this essentially means is the blood vessels going to the brain, they can lower the permeability, or the way that medicine gets through, and can deliver directly into the brain by being disrupted with the ultrasound. And then the last photo in that top row just shows the kind of way that they don't have to go through an incision into the brain to be able to deliver that therapy. The bottom row of photographs here is just providing some extra evidence of different types of therapies that could be delivered with the focused ultrasound. So things like using ultrasound-sensitive nanoparticles to cross the blood-brain barrier and deliver specific medications that way, and move on from there. So there have been multiple applications of focused ultrasound for the brain for different conditions, but we can highlight more towards the front of the brain in the picture here where that lesion for specifically Parkinson's disease is going to come into play, and that is still in that basal ganglia. So it's the same area of the brain that we look at with DBS, but now we're looking at it with focused ultrasound. And so to give a visual representation of what that looks like, so in that top left photograph, we have our kind of classic setup of what a patient would look like undergoing the procedure. So it is an MRI-guided ultrasound that is used to help target specifically the exact location in the brain that we want to lesion. The bottom three pictures here, what I can show you is the one on the left is a lesion that was made one day after the focused ultrasound was completed. The middle one is 1 week after the lesion was completed, and then 2 months after the lesion was completed. So you can see that there's a little bit of kind of extra white signal in that middle area of the brain. Does this have a pointer? No, this doesn't have a pointer, I'm sorry. But that starts to go away with time as the brain heals, but the lesion is still remained, and you can see symptom improvement from there. The other photograph, again, is just giving a representation of if you were to kind of slice the top of that MRI machine open and look straight down, this is what you would be seeing the patient looking like. So again, a little bit more visual representation of how we use the coordinates from the MRI to target specific areas in the brain in order to provide and deliver the ultrasound to that specific area in the brain to help relieve symptoms. So the way that we actually do the lesioning, so there's no incision into the scalp, but we start to spin the MRI. We have our coordinates based on the MRI. We deliver the ultrasound, and we test to see if there is symptom improvement. This will continue until we start to notice the complete benefit of what we're looking for, and will increase kind of the sonication or the dose of ultrasound delivery until we start to see the benefit that we are looking for. So one of the interesting things about ultrasound is it's described as a less invasive surgery. However, compared to the DBS, we're causing a more permanent lesion in the brain. And so I sometimes have pause before I say that this is a non-invasive procedure, because whereas DBS has modifiable changes based on how you deliver the stimulation and how you program your settings, with focused ultrasound, you have the lesion, and once the lesion is done, there is no changing that lesion. In the past, there have been other kinds of forms of radiation and ultrasound delivery for lesioning and therapy like this, including gamma knife. The main differences here are that with the MRI-guided focused ultrasound, we're not delivering radiation to you. This is we heat up the ultrasound, and it's the heated thermoablation that causes the lesioning versus the radiation-induced lesioning that we see here. So when we've looked at outcomes of how people have done after having focused ultrasound, we have seen significant clinical improvement, especially compared to placebo, in patients over time, and particularly with tremor. And so this was one of the landmark trials that really gave us the go-ahead to say, focused ultrasound is a really viable option to help with some of the symptoms of Parkinson's disease and should be considered as one of the advanced therapies for it. So again, we start to think of the different targets that we're looking at, and they really come down to the same as what we would look at with a deep brain stimulator. What we end up deciding largely is based on what are the most bothersome symptoms and features of your Parkinson's disease, and can we go in and adjust the target based on what you're experiencing. So some of the limits of focused ultrasound, as I had mentioned, is that this is a permanent lesion that forms. There is less follow-up data, as it is a newer procedure for Parkinson's disease. We have significantly less data on the outcomes in the long run compared to deep brain stimulation, and that all just comes back based on the timing of when these therapies became available and knowledgeable to us. The benefits are that you don't have to have an incision into your scalp. We don't have to have you in the hospital nearly as long, and we can see more immediate benefits from this type of procedure than we can with the deep brain stimulator, where with that, we're having you follow up with us pretty regularly to optimize the stimulation parameters and settings. And so there are definitely gives and takes between both deep brain stimulation and focused ultrasound. One of the other things that I'll argue about focused ultrasound is that for someone who maybe has a few more medical comorbidities or is not in as great of health otherwise, this is a more gentle procedure in the sense that we don't need anesthesia. You're not having to stay in the hospital as long. There are some fewer risks there. So someone who's maybe not the most ideal surgical candidate from a medical standpoint might select focused ultrasound over DBS. The other thing that I will note, though, is that right now for Parkinson's disease, focused ultrasound is only approved for one side of the body. So you can't have both sides done. And for someone who has more advanced disease, if it's unilateral, this could be great. But if someone has more advanced disease and it's affecting both sides of their body pretty dramatically, we can only address one side of the body. And so you're not going to end up reducing your medications because you're still going to have to address your symptoms from the other side. And these are kind of the important things to think about when you're discussing with your neurologist and with your neurosurgeon about which procedure should I get. So I jumped the gun a little bit talking about choosing therapies, but a lot of this is what we kind of come down to. And in this paper that was published, also looks at some of the continuous levodopa infusion devices that Dr. Curry had mentioned earlier today. But when we look at focused ultrasound and deep brain stimulation, we can see that there are kind of the differences that I mentioned, namely being unilateral versus bilateral, whether or not you need to be have an incision made for the surgery, whether there's a permanent lesion versus an adaptable lesion and a modifiable benefit or stimulus. Those are all kind of the things that we think about. And so when we look again at patient profiles, if you Google who should get focused ultrasound, who should get deep brain stimulation, you're going to come up with a lot of charts that look like this through Google. And what we really stress for these things are the symptoms that get better are the ones that get better with things like levodopa or your medications, with the exception of tremor for the reasons that we talked about. And if that's kind of the mantra that you have in your mind going into your kind of surgical evaluation, this is what we're thinking. Things, again, that are not ideal for focused ultrasound or for deep brain stimulation are, again, those features that don't really respond to levodopa, or those things like balance problems, speech problems, cognition. We really don't expect those to improve, and they can actually get worse as a side effect of either focused ultrasound or deep brain stimulation. And so we always want to make sure that we're cautioning and reviewing those symptoms before we proceed to surgery. So just a quick, easy table for you guys to see when we break down and compare deep brain stimulation and focused ultrasound. Ultimately, our goals are we want longer on times, and we want symptom control. And so when we compare the two, both can deliver those things, but only one is able to be delivered to both sides of the body. But one of them is a lot of an easier procedure, I would say, to tolerate in terms of the lesioning. So disabling motor complications, DBS is really great at that. Focused ultrasound can be helpful, but I would say DBS wins out when you're comparing the two. Refractory tremor, either option is a great therapy. And then with the accessibility of these procedures and these advanced therapies, we do still see thalamotomies, pallidotomies, and those conventional otomies, as I had mentioned in the beginning, being offered as they're more widely accessible to areas where people have less access to care, less access to follow-up, and less access to things like that. And so, in summary, what's really important is that this is an interdisciplinary approach. To select the best target, you really need to be meeting with your team. As Dr. Hess had even mentioned, an interdisciplinary team makes all the difference. making sure that the physical therapists are talking with the neurologists or talking with the neurosurgeons, and that you're all communicating clearly to each other to select, one, the best target for you, and two, select the best procedure for you. And so, in summary, DBS and focused ultrasound are both very effective options for treating Parkinson's disease. The success of the therapy really depends on identifying kind of ideal candidates for that therapy. And then choosing the therapy really does require the work of a team and you, because what this is important for at the end of the day is these are your symptoms that you're experiencing, and we want to make sure that whatever procedure we go with is really highlighting and focusing on what's going to improve your quality of life. And I think I spoke really fast, but I am finished up here. So if there are any questions, I'm happy to answer them during the panel here. And it was lovely to see all of you guys today.